Hello everyone. Now I'll be discussing about some important question in general medicine. They're all latest exam questions and likely to get repeated in your exam. First question, how will you differentiate nasal discharge from CSF? Okay, definitely we have got four options with us. Answer of this question is beta 2 transferrin. Well, this assay is highly sensitive and specific test for the presence of CSF in the body fluid, particularly in the nasal discharge. It has been employed successfully by the otolaryngologist, that is so-called ENT specialists, for the diagnosis of skull base CSF leak. Now let's talk something basic about CSF. It occupies the subarachnoid space, what they write in short as SAS. And this is the layer between this is the dura mater, this is the arachnoid mater, this is the pia mater, this is the skull bone. This is extradural space, EDS, extradural space. This is subdural space, subarachnoid space, extradural space, subdural space, and subarachnoid space. CSF lies in this place, subarachnoid space. Okay? And it also lies in central canal of the spinal cord. So with this basic anatomy, it also lies in the ventricular system around and also in the inside the brain and the spinal cord, which I told you, central canal. It is produced by ependymal cell in the choroid plexus. This is a very important point, choroid plexus. And it is reabsorbed via arachnoid granulation. Okay. I think the best example I can give to you, you must have been to swimming pool. This is a swimming pool which has got a lot of water in it. There's some filtration system is there. Water comes out of a filter, enter the swimming pool, and this is drained out and goes for filtration. This is the filtration machine, and water again come back. This is how a constant flow is there, and this water keeps on changing periodically. Exactly same thing happen in body CSF, but it is being produced by the choroid plexus and getting reabsorbed by the arachnoid granulation. You can say this is the choroid plexus where the water is getting put into the system and getting reabsorbed by the arachnoid granulation. AG is arachnoid granulation. I think this is the best example I can give to you. Now this is the beautiful arachnoid granulation. Look, this is the granulation are there, and they are in the, and they are absorbing CSF into the superior sagittal sinus. Okay, look, this is subarachnoid space. Granulation are there, and now this is going into superior sagittal sinus. This is the choroid plexus. Choroid plexus, it is producing CSF, and this CSF is going into this place. Okay, this place, that is again subarachnoid space, and this is central canal. So it is going at both the places, subarachnoid space and the central canal. Now, how much fluid is there in 125 ml of CSF at any given time? And total production per day is 500 ml. And what is the function of this CSF? It acts as a cushion and buffer. Question means well, it is acting as a so that there is no injury to the brain. Brain is a very vital and delicate organ. It looked like a cushion pad. It also gave a mechanical support and immunological protection to the brain, and also it has a auto regulation. It helps in the auto regulation of the cerebral blood flow. So cushion and protection and auto regulation of CSF flow, or cerebral blood flow to be more precise, they're all the function of CSF. 125 is a commonly asked question, so you should know these are the questions. Well, now we can take the sample by a lumbar puncture. This lumbar puncture is getting done. Patient lies in the lateral position usually, and you put a needle into the spinal cord. We can do in sitting position also, but most of the time, this is a better position. So now let me tell you what are the layers which are punctured in the lumbar puncture. Again, a very important question. Well, this is the skin, and below that is subcutaneous tissue. This is subcutaneous tissue, skin, and then we have a interspinous ligament. This is interspinous ligament, and later on it enters. This is the dura mater. It punctured dura mater, and finally it lands up in the subarachnoid space. That means number one, puncture skin. Number two, subcutaneous tissue. Third is interspinous ligament. Fourth is the dura mater, and dura mater. And in fact, before that, the ligamentum flavum also. And after that, come to dura mater, and finally it lands up in the subarachnoid space. So ligamentum flavum is also there, which are pierced by the needle. It can tell you the intracranial pressure is how much is there. You can measure by putting a meter also. And of course, we examine the CSF and we can come to know what disease is there. Well, as far as pressure is concerned, CSF pressure. How much is CSF pressure? 10 to 18 centimeter of water in the patient on the side. That is 8 to 15 millimeter mercury. 20 to 30 centimeter or 16 to 24 when the patient is sitting up position. I showed you patient can be in lying position or maybe sitting position. In both the position we can check the pressure, but definitely pressure in the sitting position is more than what we have in the lying position. Now let me tell you the CSF finding. Normal is quite clear. When it comes just like ordinary water, cells are only 2 to 5, but they are mainly lymphocytes. Glucose is 2/3 of the plasma. This is a very important point to understand. If the normal blood glucose is 90 milligram percent, then the CSF will be 60 milligram percent. In many of the books, they have written like this only, but that is not an absolute condition. Suppose the patient sugar is 600 milligram, then it will be 2/3, then it will be 400. In nutshell, you can say in diabetes, the CSF sugar goes high. Normal protein 15 to 45 milligram percent. Now let's see what happened in pyogenic. It is turbid. Cell count is highly raised and they are mainly polymorph, that is, they are neutrophils. Sugar is highly reduced, it may be near zero also. Protein are slightly increased, 1 to 2 gram. But when we talk about tubercle meningitis, it is total like fibrin web because protein get coagulated. Okay. Cells are increased, but they are mainly lymphocyte, L for lymphocyte. Here they were neutrophil. Sugar slightly reduced, but protein is highly raised, maybe up to 2 to 5 gram. And that's why it makes a fibrin web also. Viral we call as aseptic meningitis is again clear like normal. Cell count is slightly increased, but there is many lymphocyte, but sugar and protein are normal. So this is a very, very important slide. Very, very important slide. In nutshell, in viral meningitis, only slight increase in lymphocyte, protein, sugar normal. In pyogenic meningitis, sugar is near zero, but polymorphs are increased. And in tubercular meningitis, lymphocytes are increased and proteins are highly increased. This is the nutshell in summary. Question number 2. Sour taste, heartburn, erosion of teeth, excessive saliva, esophageal ulcer are seen in which condition? Is again, we have options, 4 things are there: sarcoidosis, Crohn's disease, ulcerative colitis, and GERD. It's a very frequently asked topic. The answer to this question is D, that is gastroesophageal reflux disease. There is an abnormal reflux of gastric acid into esophagus and the mouth. This you will never understand unless you know the basic concept. The basic concept goes like this. This is the lower end of esophagus. Here is the stomach. And the lining of this is squamous cell. And this is the lower esophageal sphincter. L for lower, E for esophageal, S for sphincter. It is a physiological sphincter. It remains closed all the time. Only when the person swallows, when a person is eating food, food comes, it get opened, but again it remains closed. So that's why we say it is a physiological sphincter. Now, in some time, in some diseases, in disease of GERD, this remain open. Now, this gastric content will go up, and that is called gastroesophageal reflux, or for going back, disease. It is reflux. It is not reflex. It's not E, it's X. Reflux means going back. Now, what it will lead to? Number 1, this lining of squamous will get converted into columnar lining. Suppose this is the squamous lining. Now, this will go into columnar lining. It is again a thing to defense the injury to esophagus. Cell become columnar. And this pathology is known as intestinal metaplasia. Metaplasia. Okay. Well, later on, this can get, it's a dangerous condition. It can get converted into carcinoma, Barrett's esophagus. Barrett's esophagus, which can get converted into adenocarcinoma. This lining get converted into adenocarcinoma. And there can be esophagitis. Esophagitis will be there, definitely. Okay. So let us see what all are going to happen. Heartburn and regurgitation. It's a typical symptom. Acid is coming into esophagus. Definitely when acid will come to esophagus, it will lead to burning sensation. Acid coming, it will lead to burning sensation. Heartburn. Esophagitis, as I told you, acid will go and it cause inflammation of the lower end of esophagus, which later can even go into esophageal carcinoma also. Ultimately, this acid has come to the mouth, will lead to dental erosion, definitely, and acid will lead to hypersalivation and sour taste, because mouth is getting acid, so sour taste will be there. Now this acid may enter it may enter let's say, enter the airways. It will come to the mouth. Now it is entering the airways. It can lead to chronic cough, laryngitis, asthma. Typically, cough at night. Cough at night is the classical finding that we get in GERD. And later on, dysphagia, chest pain can happen. They are late features. Treatment: proton pump inhibitor like pantoprazole, etc. we can give. We have to give B12. Iron deficiency can happen because the chronic use can lead to malabsorption. So we have to supplement B12 iron also. And they are also susceptible to Clostridium difficile infection. So that we have to be very watchful about that also. Question number 3. In ECG, the S wave represents what? Closure of aortic valve, depolarization of the ventricle, atrial depolarization, or opening of the aortic valve. Well, the answer for this question is B, depolarization of the ventricle. Let me tell you some basic. This is a P wave, Q wave, R wave, S wave, S wave, then T wave, P, Q, R, S. Now this P wave is atrial depolarization, this P wave. Or we can say this, we say electrical wave depolarization. But mechanically, it is this place where atrial contraction occur. P is atrial contraction occur. That is mechanical. After that, QRS indicate, this QRS indicate from QRS. This QRS indicate ventricle depolarization. Electrically we call as depolarization, but if you go mechanically, it indicate ventricle systole. Okay. T wave indicate ventricle dilatation or ventricle T wave indicate ventricle repolarization. What about atrial repolarization? There is no separate wave. Atrial repolarization get merged with QRS complex. There is no separate atrial repolarization. That means atrial relaxation wave get merged in QRS complex. With this background, let's talk a little bit more detail about the ECG finding. Okay. Well, regarding the P wave, I told you it's the atrial contraction or depolarization. Now, small Q wave is correspond to depolarization of the interventricular septum. Q wave also relate to breathing and are generally small and thin. They also signal of old MI. This is a very, very important question. In old myocardial infarction, prominent Q wave is a feature. Don't forget this line. You forget this line, I don't mind, but don't forget this line. R wave reflect depolarization of the main mass of the ventricle, hence it is the largest wave. S wave signifies the final depolarization of the ventricle at the base of the heart. So remember, QRS indicate depolarization. ST segment, again, let us draw this, the P wave. From here, S wave to this T wave. This is ST segment. also known as ST interval, is the time between the end of QRS complex and the start of the T wave. Okay, to the start of T wave. This is the ST segment. This is the ST segment. It reflects a period of zero potential between the ventricle depolarization and repolarization. So friends, this is the ST segment and this is the T wave. And this is a zero potential between ventricle depolarization and repolarization. T wave represents ventricle repolarization and aortic valve closure. As I told you, atrial repolarization is obscured by the large QRS complex, it gets merged. Now we talk about question number 4. Severe dehydration in a child that is not, what is not seen as a clinical sign. What he is asking, what are the signs that we see? In a case of severe dehydration, all are seen except, the answer is puffiness in the eyes. This is usually a sign of reduced serum albumin. This is not a feature of dehydration. So how do you assess dehydration in a pediatric patient with diarrhea? Well, there are certain signs which indicate severe dehydration. Lethargic or unconscious. Sunken eyes, not puffy eyes. Not able to drink or drinking poorly. The patient feels too much of weakness. Skin pinch goes back very slowly. They indicate severe dehydration. Now, some moderate dehydration, restless, irritable, sunken eyes, drinking eagerly or thirsty, skin pinch goes slowly. And no dehydration, no enough sign to classify as some or severe dehydration. Okay. So now you are clear about why the answer is puffy eyes. Well, question number 5, what is the biggest disadvantage of the device shown in the image? Options are multiple dose cannot be given, bacterial contamination, oropharyngeal delivery, not portable. Well, the right answer of this question is C, oropharyngeal delivery. This is of meter dose inhaler. Picture. They use propellant and deliver a specified dose of drug in a spray for per actuation. Convenient handheld devices that are portable, unlike nebulizers that are used bedside. This a person can take anywhere, even he is going for a morning walk, they can take in case of any difficulty, they can use. But nebulizer cannot be used in the marketplace or while in the ground. Device actuation has to be properly coordinated with the deep inspiration, in which many patients are unable to learn. And that's the biggest disadvantage of this instrument. So, one more thing, efficacy of aerolized drug depends on the particle size also. 1 to 5 micrometer or micron diameter particle deposit on the bronchiole and effectively deliver the drug. Larger particles settle in the oropharynx, while very fine particles are exhaled out. That means the particle size has to be somewhere between 1 to 5 micrometer or so-called micron. Only 4 to 10% drug reaches the actual site of action. That means the wastage is as high as 90 to 96% is wasted. A considerable fraction is swallowed also, not going to the airways, but maybe swallowed. Now we can improve spacer devices improve shallowed inhaled drug ratio. That means now when we are using spacer device, more and more drug goes to the inhalation side rather than swallow. So this is a better device. Question 6. Central venous catheter indicate are monitoring cardiac filling pressure, rapid administration of fluid to administer TPN, insertion of pulmonary artery catheter or transverse pacing wire, aspiration of air embolism. Well, they are the options that we have A, B, C, and D. Well, answer this question is all. Okay. So now let's see, when we are talking about central catheter, what the SI side, that means from where we put the wire catheter. Centrally inserted central venous catheter are primarily placed via internal jugular vein or subclavian vein. Internal jugular vein or subclavian vein. Alternative insertion site are external jugular vein or cephalic vein can be used. Now, what are the indication of using central? Remember, normally when we put, this is peripheral, in the cubital fossa or maybe in the arm also, sometimes we can use. They're all peripheral. Central means near the neck. So we can use monitoring cardiac filling pressure, especially right-sided pressure in the right atrium. Rapid administration of fluids at a time when the patient needs severe fluid immediately, then we can use, because it goes directly into the heart, so we can use rapid administration fluid. IV administration of drug fluid that are potentially damaging to the peripheral veins or tissues, vasoactive medication, parenteral nutrition. We can use this. Insertion of pulmonary artery catheter or transverse vein pressure. This is the most important indication. Sometimes we can use to aspirate air embolism also. Assess for hemodialysis or hemofiltration is again one more indication. Venous assess in the instance of difficulty peripheral venous assess, but at time we are not getting any vein in the peripheral tissues, the arm, they are all blocked. Then we can use this as a second alternative. So there are some of the indications using central venous catheter. Now let me show you a beautiful picture. Just see, we are putting a, okay, this is the central vein going into the right atrium. So we are putting a central venous catheter. Okay. Question 7. Arrange in correct sequence of step for intramuscular injection in correct order. Well, I think it's a beautiful question. Intramuscular injection, you must have given to any patient, or at least I'm sure each one of the medicos must have received the injection. Okay, what a sequence we are going to get it. Answer is A. That means, first of all, drug allergy history. Definitely. Before you give any injection, you ask, are you allergic to any drug? The first thing is, this is the first thing to be done. After that, you explain the procedure and consent also. Although in our country we avoid, but actually as per protocol, it should be. You have to tell the patient, I'm going to give injection, it's going to cause some pain. And you have to take a verbal consent. You don't need any written consent for this thing. Then hand wash, once you have done it, the patient is ready, then you go for hand wash and wear gloves. Of course, for a routine practice in India, we don't do it, but it needs to be done as per standard international protocol. Then taking syringe, collecting medication from the vial. You take the vial, you push some air, then you withdraw it. Remove bubble when the drug has come to the syringe. You remove the bubble and finally clean the skin and inject. So this is a sequence 4, 5, and 6. Okay. Well, this is a beautiful picture. You can see that the bubbles are there. You just, first we are putting a needle, withdrawing the drug, but some bubbles do come and you want to remove. You should remove the bubble. Look into this. We are giving injection after wearing the gloves. This is as per international law. It should be after gloves. Okay. Question 8. In COVID-19 patient, which drug are used to deliver respiratory complication and to reduce mortality, to relieve respiratory symptom and to reduce mortality? Well, hydroxychloroquine, remdesivir, famcivir, dexamethasone, and zanamivir are the option given in this thing, and A, B, C, D are the option in front of you. The answer is 2 and 4. That is remdesivir and dexamethasone. Well, there are 3 important papers which came in the New England Journal of Medicine. Remdesivir was superior to placebo in shortening the time to recovery in adults who were hospitalized with COVID-19 and had evidence of low respiratory infection. It's a very important line. In patients hospitalized with COVID-19, the use of dexamethasone resulted in lower 28-day mortality among those who were receiving either invasive mechanical ventilation or oxygen alone at randomization, but not among those who are receiving no respiratory support. So what we can see, these 2 drugs, remdesivir and dexamethasone, they really helped to some extent in COVID-19 patient. So that's why the answer of these 2 questions, this question is remdesivir and dexamethasone. Now let's look into hydroxychloroquine. Those who were hospitalized and used hydroxychloroquine alone or with azithromycin did not improve clinical status in 15 days as compared to standard care. So there was no extra advantage of using azithromycin or hydroxychloroquine. So as per discussion, clinician managing COVID-19 in the India, combination of remdesivir and dexamethasone were the had the maximum benefit of these 2 drugs. Question 9. Most consistent histopathological finding in the lungs of COVID-19 patient is, the answer is diffuse alveolar damage. This is seen in almost all cases of COVID infection depending on stage and severity of disease. It is also known as ARDS, acute respiratory distress syndrome. So let us learn what the basic pathology of these basic concept. The basic concept, this is the alveolus, A for alveolus, capital A, alveolus of the lung. This is the arteriole, A for arteriole, small a, pulmonary arteriole. Now the basic pathology of ARDS or diffuse alveolar damage, a protein-rich fluid accumulates in the interstitium and in the alveoli. This the fluid is there. It is a protein-rich. Okay. A protein-rich fluid accumulate in the interstitium and the alveoli. Now what will happen? This is the oxygen. Normally oxygen goes like this. Normally oxygen goes like this and CO2 come like this. Normal. But as now the alveoli and the interstitium, they contain lot of protein-rich fluid. Oxygen cannot go in because oxygen is a water insoluble gas. But CO2 can come out because CO2 is a water-soluble gas. So this is the PaO2. PaO2, partial passage of oxygen at alveolus. Here is a PaO2, small aO2. Now this oxygen cannot come in. PaO2 will remain low because oxygen cannot out. So now in that case, gradient will increase. Because PaO2 is not increasing, so in that case, gradient is increases. And as one more thing, PaO2 will go down, PaCO2 will also go down because CO2 can go out. So in this, that is the reason why we have type 1 failure. Type 1 failure in ARDS. Okay. So now if you see the X-ray or CT scan, you get ground glass appearance. Just see, lovely ground glass appearance is there. Ground glass opacity is the feature that we see in ARDS, maybe in CT, maybe chest X-ray. Question 10. You are a medical officer. Preventing treatment for iron deficiency anemia in the mass population would be, what's the best combination? The answer is go for B. That is, give a combination of ferrous sulfate, folic acid, vitamin C, and B12. This will, in that way, when you are giving this combination is available in the market, you are taking care of the iron status, you are taking care of the folic acid, vitamin C, B12, all are needed for the better improvement of the iron in a community. Okay, so we are want to give the at least to some extent we are able to compensate. What about, let's see, only ferrous sulfate? No, because many patients are deficient in folic acid, B12 also. We need to give, otherwise it will precipitate macrocytic anemia. Intravenous iron is not a treatment for mass treatment. Blood transfusion is nowhere for the mass population. Only out of these two close contender for the right answer, this is definitely far better than A, because we need to give folic acid, B12 also, and vitamin C help in iron absorption in GIT. Okay, so this is so option B is the best answer. Thank you very much.